Hyperprolactinemia, hormone, prolactin, gland, pituitary gland, anterior lobe, or prolactin acidophils, function of the hormone, milk secretion, regulation of this hormone. SIADH, thyrotropin-releasing hormone, is a prolactin-releasing hormone, while prolactin release is inhibited by PRIH and dopamine. Etiology, physiological, pregnancy, breastfeeding, breast stimulation, sleep, stress, suckling, and sexual intercourse. Drugs, anti-dopaminergic drugs, antipsychotics, phenothiazine, chlorpromazine, and haloperidol, antidepressants, tricyclic antidepressants, amitriptyline, selective serotonin reuptake inhibitors such as paroxetine, antiemetics, metoclopramide, domperidone, antihypertensives, alpha-methyl-dopa, rifenthrin, and verapamil, others, morphine, estrogen, and cimetidine. Pathological, pituitary, prolactinoma, prolactin-secreting pituitary adenoma. Almost all prolactinoma are benign. Mixed pituitary adenomas, growth hormone and prolactin, hypothalamus, tumors, and infiltrative diseases. Thyroid, primary hypothyroidism, increased TRH and increased prolactin. Renal, chronic renal failure decreases prolactin clearance, and liver cirrhosis decreases its metabolism. Clinical picture of the cause, visual disturbance due to pituitary adenoma. Clinical picture of the hormone in females, galactorrhea, persistent milk production in a female who is not postpartum, amenorrhea, hirsutism. Osteoporosis due to estrogen deficiency leads to decrease in osteoblasts and increased osteoclast activity. Infertility due to loss of estrogen, positive feedback on LH secretion. In males, gynecomastia. Impotence, decreased libido, oligospermia, and osteoporosis. Hyperprolactinemia suppresses the GnRH, causing decreased FSH and LH. Investigations for the cause, pituitary imaging, X-ray, CT, MRI, assay of the prolactin level, prolactin exceeding 250 nanogram per milliliter. It suggests probable pituitary adenoma. The normal level is less than 20 nanogram per milliliter. Treatment, dopamine agonist, the first line of treatment, such as bromocriptine 2.5 mg orally, and gradually increase to 10 mg per day. Cabergoline, drug of choice, less side effects. It decreases prolactin level with reduction of the tumor size in about 70 to 90%. Side effects, nausea, vomiting, abdominal pain, and hallucinations. Surgery for macroadenoma not responsive to medical treatment, irradiation, proton or alpha particles, treatment of the cause such as myxedema, pituitary tumors, tumor type, prolactinoma, secretory products, prolactin, relative frequency, 50%, somatotroph adenoma, growth hormone, 10%, corticotroph adenoma, ACTH, 5%, thyrotroph adenoma, TSH, 1%, non-secreting adenoma, no secretory products, and finally, the frequency is 34%. Nelson's syndrome, big pituitary adenoma with very high ACTH and hyperpigmentation after bilateral adrenalectomy in a case of pituitary Cushing, pituitary apoplexy, endocrinal emergency, sudden enlargement of the pituitary by hemorrhage into the tumor, causing combination of pressure manifestations such as visual defects and panhypopituitarism. Panhypopituitarism in adults, loss of anterior pituitary function. Etiology, destruction of the pituitary gland by surgery, irradiation, tuberculosis, sarcoidosis, hemochromatosis, Sheehan syndrome, pituitary infarction after severe postpartum hemorrhage, pituitary apoplexy, hemorrhage in pituitary tumor, genetic, isolated growth hormone or GnRH deficiency, autoimmune. Clinical picture of the cause, surgery, severe postpartum hemorrhage. Clinical picture of hormones according to the frequency of appearance, 2G. Growth hormone and gonadotrophins, FSH and LH, are lost early, then TSH, then ACTH deficiency. Gonadal deficiency, for females, amenorrhea, decreased libido, infertility, loss of pubic and axillary hair. For males, impotence, decreased libido, infertility, loss of pubic and axillary hair. Growth hormone deficiency in adults, fasting hypoglycemia, osteoporosis, and fine wrinkles. In children, growth hormone deficiency only, short stature with proportionate dwarfism, growth hormone with FSH and LH deficiency, dwarfism with infantile proportions, upper greater than the lower segment, and span shorter than height. Then we have TSH deficiency, resulting in secondary hypothyroidism. In contrast to primary hypothyroidism, hypercholesterolemia is rare, skin is thin with wrinkling, and no menorrhagia in secondary hypothyroidism. Very important MCQ note. ACTH deficiency resulting in secondary adrenal insufficiency. It stimulates Addison's disease, but no pigmentation because of absent ACTH, and no marked hypotension due to normal aldosterone. Prolactin, low with failure of lactation in Sheehan syndrome. It may be high in lesions causing pituitary stalk compression. Coma, due to hypoglycemic coma from decreased GH, growth hormone, and cortisone. Myxedema coma, pressure in cases of pituitary tumors. If the patient has associated diabetes insipidus, the problem is in the hypothalamus. Differential diagnosis from primary Addison's disease, primary hypothyroidism, from anorexia nervosa, normal hair and breast, aggressive attitude, normal cortisol, and high growth hormone due to hypoglycemia. Investigations. For the cause, pituitary imaging, X-ray, CT, and MRI, assay of hormones levels, decreased growth hormone and insulin growth factor 1, FSH, LH6 hormones, TSH, T3, and T4, ACTH, cortisol, prolactin low or high according to the cause. Investigations of the function of the hormone, hypoglycemia, hyponatremia, stimulatory test, insulin tolerance test. It is a gold standard for diagnosis of growth hormone deficiency. After overnight fasting, regular insulin 0.1 unit per kilograms is given. Normally, positive response, increasing in the growth hormone to more than 7 nanogram per milliliters. In pan-hypopituitarism, negative, no stimulation. Treatment of the cause and replacement therapy. Replacement therapy, multiple hormones must be replaced. Hydrocortisone, 30 mg per day, 20 mg AM and 10 mg PM. Gonadotrophin deficiency. If fertility is not a problem, in males, testosterone, and females, estrogen with progesterone. Infertility. If fertility is a problem, in both males and females, LH, human chorionic gonadotropin, FSH, human menopausal gonadotropin, GnRH may be occasionally used. TSH deficiency, oral levothyroxine. It should be started after a steroid replacement to avoid acute adrenal failure. ADH deficiency, desmopressin, intranasal, subcutaneous, and oral. Recently, purified pituitary hormones, hypothalamic releasing factors. Differential diagnosis of short stature, familial and constitutional, the commonest. Endocrinal, decreased growth hormone, levoleurin, Frolix, and Lawrence-Moon-Bellel. Decreased T4, cretinism, and juvenile myxedema. Increased sex hormones, precocious puberty. Increased cortisol, Cushing or excess cortisone therapy. Type 1 diabetes mellitus, levoleurin syndrome, proportionate dwarfism, hypogonadism, normal mentality, Frolix syndrome, trunk obesity, hypogonadism, polyphagia, and mental retardation, Lawrence-Moon-Bellel, like Frolix, plus skull deformity and retinitis pigmentosa, chronic severe illness during childhood for CVS, severe rheumatic fever, congenital heart diseases, chest, polycystic lung disease, and TB, GIT, malabsorption syndrome and malnutrition, kidney, chronic nephritis. Skeletal causes, congenital and acquired, congenital achondroplasia, short limbs with normal trunk, osteochondrodystrophy, both limbs and trunk are short and deformed, acquired, rickets, spots of the spine and pagettes of bone. Genetic causes, Nonan's syndrome, Turner syndrome, and Mongolism or Down syndrome. Diabetes insipidus, physiology, hormone, ADH, antidiuretic hormone or arginine vasopressin, gland, pituitary gland, posterior lobe. ADH is synthesized in hypothalamus, mainly in supraoptic nuclei, and then transported along axons and stored in the posterior pituitary. Functions of the hormone: increased watery absorption by collecting tubules. Large dose leads to vasoconstriction of blood vessels. ADH receptors, site and action. V1 vascular receptors are in high density on vascular smooth muscle. Function: vasoconstriction, platelets aggregation, and prostaglandin synthesis. V2 receptors on the renal collecting duct, which are responsible for increasing water reabsorption. Also, release of von Willebrand factor and factor VIII from vascular endothelium. V3 stimulates the release of adrenocorticotrophic hormone, ACTH. Regulation of this hormone is increased by increased osmolality, hypovolemia, hypotension, drugs such as nicotine and barbiturates. It's inhibited by decreased osmolality, hypertension, and cold weather. Etiology: central DI, damage of the hypothalamo-hypophyseal axis, idiopathic, hereditary, autosomal dominant, or recessive, or X-linked recessive. Injury after hypophysectomy, the treatment of acromegaly. Infection, TB, infiltration, sarcoidosis, ischemia, Sheehan syndrome and shock, pituitary tumor adenoma, and craniopharyngiomas. Pregnancy. Deficiency of ADH can result from increased metabolism by placental enzyme vasopressinase enzyme. It resolves within few weeks after delivery. Familial DI or Wolfram syndrome, DID-MOAD, DID-MOAD. Hereditary conditions in which there is a defect in osmoreceptors. Osmoreceptors are present in anterior hypothalamus. Diabetes insipidus, DI. Diabetes mellitus, DM. Optic atrophy, O, and D for deafness. Nephrogenic DI, renal tubules not responding to ADH. Hereditary, X-linked recessive, so males are predominantly affected. Acquired, chronic renal failure, sickle cell disease. Kidney amyloidosis, sarcoidosis, acute tubular necrosis, polycystic kidney pyelonephritis, hypercalcemia, and hypokalemia. Drugs, lithium, colchicine, demeclocycline, and cisplatin. Clinical picture of the cause, history of hypophysiectomy, clinical picture of the hormone, polyuria, more than 3 liters per day of dilute urine, up to 20 liters per day, and nocturia with polydipsia, severe dehydration, weakness, weight loss, and fever. Neurological manifestations due to hypernatremia, hypovitaminosis of water-soluble vitamins, complications, shock, and death. Differential diagnosis of polyuria. Investigations for the cause, pituitary imaging, X-ray, CT, and MRI, assay of the hormone level decreased, investigations of the function of ADH, urine analysis, polyuria with low specific gravity, no pathological constitutes. After fluid deprivation, polyuria persists. Plasma osmolality increased due to loss of free water. Polyuria with urinary osmolality of less than 300 milliosm per kilogram and specific gravity less than 1005 are the hallmark for diagnosis of diabetes insipidus. Again, plasma osmolality is high. Urine osmolality, milliosm per kilogram. If after fluid deprivation is less than 300 and after ADH administration more than 750, then this is central diabetes insipidus. If after fluid deprivation is less than 300 and after ADH administration still less than 300, then this is nephrogenic diabetes insipidus. If after fluid deprivation is from 300 to 750 and after ADH administration is less than 750, then this is hysterical polydipsia. Then we have stimulation tests. Test for the hypothalamus by nicotine test, 1 to 3 mg nicotine, normally oliguria due to stimulation of ADH. If central diabetes insipidus, negative, no stimulation. Test osmoreceptors, IV hypertonic saline, sodium chloride 2.5%, normally oliguria. Osmoreceptors defects, negative, no oliguria. Test kidney, vasopressin test, to differentiate between central diabetes insipidus and nephrogenic diabetes insipidus. In central, oliguria, concentrated urine. In nephrogenic, no change. Treatment, replacement therapy, synthetic ADH desmopressin, 20 microgram per day, intranasal. Diet, decrease sodium and increase vitamins. Drugs, 3 C's, chlorpropamide for central, carbamazepine in nephrogenic, and SIADH may be used in nephrogenic. Amiloride, okay, I'm right. Potassium-sparing diuretic is the drug of choice in lithium toxicity-induced diabetes insipidus. Differential diagnosis for polyuria, physiological, winter month, excess coffee or tea. Diuretics, physiological, hysterical polydipsia. There is a comparison between diabetes insipidus and hysterical polydipsia. Clinical picture, in diabetes insipidus, polyuria, then polydipsia. Fluid deprivation test, polyuria persists, while in hysterical polydipsia, clinical picture, polydipsia, then polyuria. Fluid deprivation test, no polyuria. Osmolality is high in diabetes insipidus while it's low in hysterical polydipsia. Pathological, endocrinal, diabetes insipidus with its causes, diabetes mellitus, adrenal, Addison's, thyroid, thyrotoxicosis, it increases metabolic water, parathyroid, hyperparathyroidism, renal, nephrogenic diabetes insipidus, chronic renal failure, diuretic phase of acute renal failure, after any attack of migraine, epilepsy, bronchial asthma, also after internal medicine. Okay, I'm sorry, I'm not gonna say that. Syndrome of inappropriate ADH secretion, SIADH, physiology, referred to diabetes insipidus as we explained it. Etiology, tumors release ADH, oat cell carcinoma and lymphoma, pulmonary lesion, Legionella pneumonia and TB, CNS meningitis, encephalitis, and head injuries. Drugs, chlorpropamide, carbamazepine, and cyclophosphamides. Clinical picture. Increased ADH causes water retention, dilutional hyponatremia, weight gain, weakness, confusion, convulsions, and coma. No edema because of natriuresis. Investigations. Decreased sodium, less than 130 milliequivalent per liter. Decreased serum osmolality, less than 270 milliosm per kilogram. Increased urine sodium concentration, more than 20 milliequivalent per liter. Treatment. Fluid restriction, 0.8 to 1 liter per day. Demeclocycline, 600 to 1200 mg per day. It inhibits the action of ADH, given to the patient unresponsive to fluid restriction. For severe hyponatremia, hypertonic saline, 5% IV slowly. Myxedema, hypothyroidism in adults, physiology, refer to hyperthyroidism as we have read it, etiology and types. Primary myxedema, idiopathic atrophy of the gland, iatrogenic, post-thyroidectomy, radioactive iodine, antithyroid drugs, lithium, imidazole, infections, viral infections, decurvent thyroiditis, iodine deficiency, infiltration by tumor, Hashimoto's thyroiditis, the most common cause of primary hypothyroidism in developed countries, autoimmune disease, thyroid antibodies positive, gland is replaced by lymphocytic infiltration, gland is firm, enlarged, not tender, and may be nodular. Transient thyrotoxicosis may occur, followed by hypothyroidism. There is increased risk of thyroid carcinoma and thyroid lymphoma. Secondary myxedema, secondary to pituitary failure, tumor, decreasing the TSH. Tertiary myxedema, deficiency of TRH secreted from hypothalamus. Peripheral resistance to thyroid hormone, this is very rare. Clinical picture, it's more in females than males, 30 to 50 years. Clinical picture of the cause, surgery, antithyroid drugs. Clinical picture of the hormones. In hypothyroidism, everything slows down except the period. General, intolerance to cold, lethargy, and fatigue. Weight gain due to decreased metabolism, retention of fluid, and constipation. Serious effusions, pleural, pericardial, and ascites. Face, expressionless with puffy eyelids, eyelids drop, decrease of adrenergic drive, loss of outer 1/3 of eyebrows, large tongue, GIT, slow motility, constipation, slow absorption, malabsorption syndrome, genital, menorrhagia in primary hypothyroidism due to deposition of mucopolysaccharides in uterine muscles that weaken their contraction, while in secondary hypothyroidism there may be amenorrhea, gonadotropin deficiency for males, impotence, and gynecomastia. Cutaneous, dry, cold, pale, and non-sweaty skin, non-pitting edema due to intradermal accumulation of proteins, not interstitial edema fluid, yellowish discoloration due to cretinism and hair loss, cardiovascular system, hypercholesterolemia, ischemic heart diseases, diastolic hypertension due to decreased thyroxine, which leads to vasodilatation in normal conditions, sinus bradycardia, and pericardial effusion, CNS, slow intellectual and motor activity, depression, frank psychosis, myxedema madness, deposition of mucopolysaccharides in tongue, slow speech, vocal cords, hoarseness of voice, flexural retinaculum, carpal tunnel syndrome, peripheral nerves, peripheral neuropathy, joints and muscles, slow, relaxed reflexes, hematological, microcytic hypochromic anemia, iron deficiency anemia due to menorrhagia, macrocytic anemia associated pernicious anemia, hypothyroid coma or myxedema coma, untreated long-standing hypothyroidism precipitated by cold exposure and infections, manifested by 5H, hypothermia, hypoglycemia, hypoventilation, heart failure, hypotension, hypothyroidism with loss of consciousness. Although this condition is called myxedema coma, frank coma is uncommon. Mortality rate of myxedema coma is 50 to 75 even with treatment. Gland enlarged as Hashimoto's thyroiditis, atrophy, primary idiopathic forms, scars of previous operations, subacute thyroiditis, tender, enlarged thyroid, sometimes the pain can relate to the jaw, typically following viral upper respiratory infection, decurvent thyroiditis, or autoimmune postpartum thyroiditis. It begins with hyperthyroid symptoms, then hypothyroid symptoms, elevated ESR, antithyroid antibodies, antithyroid peroxidase, or antithyroglobulin antibody. Radioactive iodine uptake is low, typically self-limited within weeks or months, just cortisone or aspirin in severe cases, and beta blockers to decrease palpitation in some cases during hyperthyroidism phase. Differential diagnosis, nephrotic syndrome, depression, other causes of hypothermia, cold weather shock. Difference between primary and secondary or pituitary myxedema. Clinical picture for skin, depigmented, thin with wrinkling in pituitary, while in thyroid myxedema, coarse and thick. Macroglossia and menorrhagia, they are not present in pituitary myxedema but are present in thyroid myxedema. Investigations, TSH, FSH, LH, ACTH are low in pituitary myxedema, while TSH is high in thyroid with normal FSH, LH, and ACTH. Hypercholesterolemia is rare in pituitary myxedema but common in thyroid myxedema. Investigations for the cause: TSH, the most sensitive test for primary thyroid disease. It's increased in thyroid myxedema while it's decreased in pituitary myxedema, as we previously mentioned. Thyroid antibodies, assay of hormones levels, serum hormones, TSH increased in primary type. Test of choice, T4 and T3 are reduced. It's important to note that normal T4 doesn't exclude hypothyroidism. Radioactive iodine uptake is low. Investigations of the hypofunction of thyroid hormone: blood, CBC anemia, blood glucose, flat sugar curve, increased cholesterol and prolactin, increased CPK and LDH, ECG findings, sinus bradycardia, and low voltage. Differential diagnosis of low voltage ECG: hypothyroidism, obesity, and pericardial effusion. BMR or body metabolic rate is low. Basal metabolic rate is low. Treatment: lifelong thyroxine therapy and treatment of myxedema coma. Lifelong thyroxine therapy, T4 or levothyroxine, sodium L-troxin, 50 microgram, 1 tablet daily for 3 weeks, then maintenance dose at 100 to 150 microgram daily. 6 weeks should pass before repeating thyroid function tests following a dose change. It's necessary to measure thyroid function every 1 to 2 years. The dose is increased gradually to avoid precipitation of angina and heart failure. Treatment of myxedema coma: hypothyroidism, large doses of T4, 200 microgram IV and maintenance 50 microgram per day IV, or T3, 40 microgram IV and maintenance 10 microgram IV per day. Hypothermia, rewarming slowly to avoid arrhythmia. Hypoglycemia, glucose IV. Hypoventilation, tracheal intubation and mechanical ventilation. Heart failure and hypotension, cardiac support. Treatment of precipitating factors, antibiotics for infections. Cretinism, hypothyroidism during infancy. Physiology, refer to hyperthyroidism as we have previously mentioned. Etiology, congenital endemic cretinism, iodide deficiency, excess antithyroid drugs during pregnancy. Clinical picture: hoarse cry, feeding problems, disproportionate dwarfism, big lips, protruding tongue, delayed dentation, delayed walking, dry cold skin, muscle weakness, pot belly with umbilical hernia, mental deterioration if not treated within 6 months, persistent physiological jaundice. Investigations: reduced T4 and T3 while elevated TSH, X-ray of carpal bones, delayed appearance of ossification centers. Treatment: replacement therapy, L-thyroxine 0.025 mg per day, and increase the dose up to 0.2 mg per day. It should be started before the first 6 months to avoid mental retardation. Goiter. Goiter is the enlargement of the thyroid gland. Classification: simple toxic inflammatory goiter and neoplastic goiter. Inflammatory goiter such as Hashimoto's thyroiditis. Toxic goiter, goiter with hyperthyroidism. Diffuse in Graves, and toxic nodular goiter is a secondary thyrotoxicosis or Plummer's disease. Simple goiter or euthyroid goiter, non-toxic, non-inflammatory, and non-neoplastic. Persistent low level of thyroid hormones, increased TSH. Thyroid enlargement, physiological, puberty, pregnancy due to increase of the demand of iodine, so there is relative iodine deficiency. Drugs, antithyroid drugs, lithium. Clinical picture: soft symmetrical thyroid swelling. Investigation: slight elevation of the TSH, normal thyroid scan and antibodies. Treatment: in young, thyroxine 100 to 150 mcg per day orally to suppress the TSH. In elderly, thyroxine is contraindicated as goiter rarely decreases in size. Large goiter, surgery for cosmetic purpose and compression symptoms. Hypoparathyroidism or tetany. Definition of tetany: state of increased neuromuscular irritability due to decreased ionized calcium, decreased magnesium, or alkalosis. Etiology of tetany: hypocalcemia, ionized calcium less than 4.65 and total calcium less than 8.5 mg per deciliter. Hypoparathyroidism: surgical removal, polyglandular autoimmune syndrome type 1, irradiation, DiGeorge syndrome, absent parathyroid and thymus glands. Pseudohypoparathyroidism: resistance of parathormone, decreased calcium intake, starvation, decreased calcium absorption, malabsorption syndrome, and vitamin D deficiency. Calcium is low, alkaline phosphatase and parathormone hormones are elevated. Precipitation of calcium in tissues such as acute pancreatitis, sepsis, burn injury, tumor lysis syndrome, and increased calcium excretion. Chronic renal failure is the most common cause of hypocalcemia. Tetany rarely occurs in renal failure because of acidosis, which converts non-ionized calcium into ionized calcium. Hypomagnesemia, excess diuretics, malabsorption syndrome. alkalosis, ionized calcium to non-ionized calcium. Atherosclerotic alkalosis, any case of hyperventilation. Metabolic alkalosis, loss of HCl, vomiting, gastritis, gastrectomy, milk-Ackley syndrome, hypokalemia such as Conn's syndrome. Hypokalemia leads to alkalosis, and alkalosis leads to hypokalemia and vice versa. Clinical picture of tetany, latent tetany. Serum calcium is from 7 to 9 milligram percentage. Manifestations of tetany are not present. Manifestations appear by provocative tests, Travestic test, tapping over the facial nerve, contraction of the facial muscles, Trousseau test, inflation of blood pressure cuff over the systolic blood pressure for 3 minutes. After then we have carpal spasm. Erb's test, normally 8 milliamperes at least are needed for stimulation. Electrical current less than 4 milliamperes leads to muscle contraction. Manifest tetany, serum calcium less than 7 milligram percentage, irritability and paresthesia around the mouth and fingers, and this is the first presentation. Muscle twitches, maybe convulsion in severe cases. Spasm, eyelids, blepharospasm, mouth, trismus of jaw, larynx, laryngospasm, carpopedal spasm, diaphragm hiccup, and finally the GIT abdominal colic, CVS, QT prolongation, refractory heart failure, hypotension, on ectodermal structures only in hypocalcemia, brittle nail, hypoplastic teeth, and cataract. Investigations for the cause in hypoparathyroidism, decreased parathormone hormone, decreased serum calcium, and increased phosphorus. CT scan may reveal bilateral symmetrical basal ganglia calcification. Chorea or Parkinsonism are present in 20 to 30% of the patients with basal ganglia calcification. Hypoparathyroidism is the most common cause of pathological basal ganglia calcification. In alkalosis, increased pH with decreased ionized calcium. In hypomagnesemia, refractory hypokalemia, treatment, acute attack IV calcium gluconate, 10 milliliters, 10% very slowly. Treatment of the cause, hypocalcemia. The main two agents are oral calcium and vitamin D. Hypomagnesemia, oral magnesium. Alkalosis, treatment of the cause, acidifying drugs. Pseudo-hypoparathyroidism. The level of parathormone hormone is high, but there is resistance to all its actions. There are hypocalcemia and hyperphosphatemia. It's a genetic disorder, autosomal dominant. There are 3 different forms. Type 1A, Albright's hereditary osteodystrophy, short stature, round face, short hand bones, shortening of the metacarpals, particularly the 3rd, 4th, and 5th, manifestations of hypocalcemia. Type 1B, resistance to parathormone hormone, only in the kidneys, normal appearance, plus clinical picture of hypocalcemia. And finally, pseudo-hypoparathyroidism. The same presentation as type 1A, but it's biochemically normal. Hormone resistance is not present, and this concludes our part for today.